Good evening, everybody, and welcome to yet another RACGP Victorian Faculty free webinar. Tonight we've got a presentation on supporting recovery and return to work for patients with pain and mental health conditions. This is a joint webinar sponsored by TAC WorkSafe Victoria. I'm Michael Aufgang. I'm a GP in Altona Meadows and happen to be on the Victorian Faculty Board. I'll be facilitating the webinar tonight, and we please want you to make sure that you ask many questions because this is an interactive webinar. We've managed to retain 54 people and we are expecting another 450 odd. So please be patient when you ask your questions if you're not answered straight away. Because there may be one or two other people that are joining. I'm told that my delusional numbers are actually a few hundred over, but that's all right. We'll let you know the numbers that have joined as we go. I'd just like to introduce the panel. We start off with Dr. Ben Barisi. Ben's a GP with an interest in sports medicine, WorkSafe and substance misuse. Carolyn Arnold. Carolyn's Head of Pain Medicine at the Alfred and Monash Networks. She's Professor in Rehab Medicine. Dr. Dielle Fellman. Hi. She's a consultant psychiatrist and she's got an interest in the occupational health space. And Dr. Peter Cotton, psychologist. Peter's a clinical psychologist and his interests include Beyond Blue, WorkSafe and Super Friends. During the broadcast, you'll find that the webcam will be switched on and off. It's not just because of us, it's also so that you'll have a good vision of the slides that we'll be showing you. There will be RACGP, QI and CPD points allocated for attending, and certificates will be sent in a few days via email, together with the details for the recording and the slides from tonight's session. There will be a survey sent immediately after the session and tomorrow. And if you could take a few minutes to answer the questions, that'd help us improve our services and quality of the webinars. The session is being recorded and thankfully voice is active, and it'll be uploaded onto the Vic Faculty website and be sent out to all attendees. That may take a week for the email to arrive due to editing and other sorting. I'll just cover a few. I'll just cover a few technical aspects of the platform for those who are joining the webinar for the first time, and then we'll get started. Okay, where's my technical sheet? Gone. All right, I've lost a sheet, everybody. I don't know where it's gone, and that's not it. Okay, so the technical aspects are that we have the ability at the top of the screen for people to ask questions, and I think there's a little red flag that you can wave if you have a question, but we prefer for you to be sending the questions via the little messaging questionnaire that you'll see on your screen. There's an audio box that tells you that all attendees are muted. You can listen through your speakers or you can use that via your telephone if you've got audio problems. If you want to hide the panel, at the top there's a little sidebar that you can click on, and that'll move the sidebar across. And I think at that note we may commence the webinar. Okay, learning outcomes. Okay, so our learning outcomes are to increase the awareness of the relationship between mental health, acute and persistent pain and work-related injury, We need to identify key principles and provide practical strategies for assessing and managing comorbid pain and mental health conditions in relation to work-related injuries. Increase awareness of the important role of GPs and other health providers in setting recovery and treatment expectations for their patients. And lastly, to increase awareness of services to support GPs in management of these patients. I'll hand over to Ben.
Thank you, Michael. I was just going to give an overview of how the webinar will work. So, first of all, the basis is to provide you with some information on how to support workers and recover in terms of patients with mental health conditions. We'll then be going on to speak about how to assess pain and mental health conditions in injured workers. We'll then go on and talk about management of such patients. We'll talk about a case study. And at the end, we'll give you some resources that you can use to assist workers in this area. I'll now hand over to Carolyn.
Okay, so we're going to be talking about pain. So what I've got here on this slide is the definition of pain, which is an internationally accepted definition that it's an unpleasant sensory and emotional experience. And I think it's very important to remember that pain is something that is learned through experience right from our early days, even probably prenatally. And so it's really much a very developed kind of conceptual thing, which starts possibly with nociception but is complex. And we'll see that in the way people experience pain in illness. So I think what we really strive to do is always to accept the patient's report of pain as being their experience and how they describe the pain, and try not to judge the experience too much. In the next slide, I've just tried to give you a contemporary view of pain. Some of you may be familiar with the mind-body separation and the description of Descartes, who described the revelation, really, that when somebody had a peripheral sensation, they experienced it because they could sense it centrally. And I think now, on the right-hand side of the slide, we have a much more dynamic view of pain as being a two-way traffic with inhibitory and excitatory factors. Some of them are learned, some of them relate to the current experience, and that these factors can modulate the pain experience. So it can depend on the context of the pain, it can depend on the mood, it can depend on the existing state of the nervous system and how it responds maybe from previous experience or from things that have been learned. So it's very dynamic, and there's no direct relationship between a particular sort of injury and the amount of pain or the duration of pain that a person will experience. It's incredibly individual, and it's more than just a nociceptive response. So I guess what I'm trying to say is that pain no longer is a linear relationship between stimulus intensity and the response. And I think this very complex phenomena is increasingly recognising the role of central processing. And a good example of this for me always is an example of a footballer who has a very serious injury during a match, but despite a lot of pain, he continues to play. Old folk might remember a famous Hawthorn footballer who I think had a pneumothorax and finished the grand final, kicked a goal. And he didn't really feel his pain at the time. I'm sure he did afterwards, but in that context, he was good. And the alternate experience is a common one that I see in my practice, and one I can give you as an example is a man who was a butcher, and he was worried about a bar in his workplace, which was above where he was working, and he was telling his employer that this bar was a risk to health and safety. And sadly, what happened is one day when he was butchering on the bench, he hit his head very badly on the bar and got neck pain. And his immediate response really was extreme pain, but also anger, because this was to him an avoidable accident, and now he was a victim of that injury. And those are two opposite examples of how the context of the injury is very important in understanding what follows. And so just to remind you again that it's always an excitation and inhibition working together. And the other concern when pain persists is that sometimes it's actually becoming maladaptive. Some of the changes are not useful and helpful. In acute pain, we always find that it's a good thing because it leads you to change your behaviour, which can stop the pain, for example, if you're burning your finger. But sometimes in chronic pain, even though a person might do a lot to make it go away, it can still continue in a disproportionate way. And that's why we have to broaden our thinking about it very much. So the next slide, I've attempted not to bore you with a great deal of detailed information about central processing, but to remind you how very important it is that there are lots of different cortical areas that are involved in responding to pain, and these are from functional MRI studies. So it involves the prefrontal cortex, the anterior cingulate cortex, and some of the brainstem nuclei. All of these sites are active and involved in the experience of pain. So really what we've been saying is that pain's actually very complex. So the obvious follow-on from that is that monotherapy is rarely going to be effective in treating chronic pain. A complex thing often requires multifaceted treatment. So, and sometimes we use an analgesic or a simple procedure as a window of analgesia to try and address some of the functional implications of pain. So if someone has a medication that partially reduces their pain, or even a small procedure, that is the window of opportunity to address the problems like the inactivity or the loss of functional strength, maybe to look at some of the psychological factors that are involved and to start to work towards the functional gains, because often that analgesia may not persist unless you restore these other functions. So in the next slide, I guess we're starting to move into the kind of where do we overlap. This is really the central theme of this slide, which Dale's probably going to talk to, but I guess we're overlapping conditions here where, you know, people would say, what is the difference between depression and pain? And I guess it's really a spectrum. And on one end, we know that people with depression have often got somatic symptoms of pain. And we also know that in the chronic pain population, if we look and we assess them, we will find high incidence of major depression. So there's really a complex interplay here, and they're both relevant to the patient's experience.
Yeah, and I think it's really important to recognise when both occur, because the prognosis can be much worse and early treatment is essential in improving outcomes. Yeah. Moving on to the next slide. This slide is really just to demonstrate how mental health and pain can interact with each other. So it's quite a simplistic slide, but essentially the first way is pain can be organic in nature, and psychiatric symptoms can develop secondary to that. That can occur in many ways. What I often see in my clinical practice is people develop depression not when the pain first starts, but at some time after they've had pain. So potentially months after pain first arises, and often it occurs when the person expects that they should have recovered by that point. So they go, they're doing okay, then they realise, gee, I'm not better, and they realise the impact on their life in terms of their work, their relationships, their recreational pursuits, and they realise how disabled they are, and often I see depression start then. The same for anxiety disorders. Anxiety disorders very commonly emerge when shortly after pain starts or can be delayed. And it's not just anxiety about things such as what does this mean for my work, what does it mean for my livelihood, what does it mean for my relationships. But what I also see is a group of population who have that kind of pain avoidance behaviour, so stop doing things and become more and more isolated and impaired, and then they almost become agoraphobic, and in fact quite a percentage of them do become agoraphobic as they become more isolated and functionally impaired. The next point is that psychiatric, so back to the previous slide, psychiatric symptoms can contribute to the development, perpetuation or amplification of pain. That's pretty self-evident. If someone's got a primary psychiatric disorder such as depression or anxiety, they may be more prone to experiencing pain as more severe, and the pain may have bigger functional impacts. I've put the somatic symptom disorder there. Just most of you will probably know that DSM-5 has got rid of the pain disorder and replaced it with a somatic symptom disorder. The main rationale for them doing that really is to say, well, let's take the focus away from whether pain is organic or non-organic, and let's focus on what the thoughts, feelings and behaviours around that somatic symptom being pain are.
I was going to say something too. I mean, in this slide, we've also mentioned the sort of markers of vulnerability, which is to do with the history that's really important to obtain, and things like looking for family history of depression, even sort of deprivation as a child or abuse in childhood, early loss of a parent, or a history in the family or in the patient of substance misuse. These are factors that increase the vulnerability of the pain as becoming a long-term problem.
And just to echo Dale's point, there's often a particular interaction between, if someone has post-traumatic stress disorder and pain, there can be a reciprocal interaction where the acute pain experience or exacerbation of pain can trigger flashbacks, and there can be an escalating cycle. So some of these people become quite distressed and disabled very rapidly.
I also see that phenomenon not just in PTSD, but where there's workplace bullying and harassment and the person is traumatised but also has a physical injury, and their experience of pain can then make them recall and think about more significant the workplace trauma, then it deteriorates in a vicious cycle.
Just to go back to Carolyn's point, some of those issues around vulnerability, as GPs, we really are in the prime position to have that background of the patient, knowing and understanding a lot about their development and their past history. So it's very important.
Yeah, I mean, the other thing we've mentioned in this slide is the fact that sometimes there is other medical history that points to the fact that there might be a risk of persisting pain becoming problematic, and it's important to take a history of things like whether they've got migraine sufferers, whether they have TMJ, joint disorders, conditions like tension headache, interstitial cystitis, irritable bowel. These conditions are associated with what we call pain sensitization, which we'll talk about a bit more, but they seem to be people who have a heightened response and sensitivity when they have an injury, or even that the injury may resolve but they'll continue to experience pain because the nervous system has been sensitized, so which means that some of these dynamic pathways have actually been overexcited and, if you like, the volume's ramped up too much. So all that corroborative history is going to be really helpful in formulating the risk of chronicity and also the timing of what you're going to do to manage it, not just to treat it purely as a nociceptive issue.
This next slide is really just to give you an indication. This is data from our Victorian scheme. There's a couple of years lag, but it's pretty consistent nowadays. So if you take into account not only what we call in the jargon primary mental injuries or psychological injuries, but secondary psychological injuries, that means people develop a mental health problems that are significant enough to warrant diagnosis secondary or as a reaction to their primary physical injury. Specifically in relation to pain, persistent pain, it's nearly half that population do develop secondary psych injuries. But in total, when you put all of that together, that's just over a third of claims in our total claim pool. So just a very significant number of people in this space.
If I could just add here, I know that does add, unfortunately, a challenge being the GP in terms of working out what is the primary injury, what is secondary psych condition, what's a primary psych condition. So that's a challenge that we all face in terms of how we assess these patients.
Can I just say something about that too? Because often with the insurer, they're always trying to carve out what is physical, what is psychological. But if you're actually managing a patient, you can't just treat one part. You've got to take the whole person and treat both things together to get an outcome. So I think you'd be careful of seeing the importance of both of those in management. We wanted to just give you a bit of a thumbs up on the risk factors for chronic pain, and we've already started to touch on that with the previous slides. But from a medical point of view, I think it's worth noticing that where there's a nerve injury in an injury or an illness, that does increase the risk of the person going on having difficult to control chronic pain. Not all people with a nerve injury will get chronic pain, but there's a higher percentage who will. So these are the factors you need to look out for. I think that there are always some inherent factors in an individual, and some of these are in biological and environmental factors. Some examples of this could include a history of smoking, which is associated with poor outcome in back pain. Even drug exposure over life history or currently can have an impact on how the pain responds within the nervous system. And there may be other environmental factors that are risks for chronic pain.
We've already touched on the relationship between chronic pain and PTSD and depression. Recent research has highlighted that various mental health disorders, pre-existing mental health disorders, are risk factors in and of themselves for the development of persistent pain. So the most well-researched are PTSD and depression, personality disorders also. So they're the three key areas that have been looked at.
These aren't illnesses of themselves, but they're obviously cognitive styles. People who focus on their symptoms, people who catastrophize their pain and what the pain means, and I think most importantly, people who engage in fear avoidance behaviours, so avoid things that might potentially exacerbate their condition or exacerbate their level of pain, have worse outcomes. Cultural factors are really important, specifically cultural views regarding mental illness, cultural views regarding stigma, cultural views regarding sickness and the sick role. Developmental history is also an important risk factor for prolonged functional impairment. The most prominent ones there are prejudicial childhood, so early childhood loss, deprivation or childhood traumas. Also modelling, so if there's been a family member or another relative or close person that's had a prolonged illness and has been in the sick role, then outcomes can be worse for that person too. Work factors can also impact on the prognosis, mostly high stress roles, work dissatisfaction, jobs where there is low control and high demand, so where there's a low locus of control, and also where people feel unsupported. And specifically we see this if there's a workplace injury, a physical injury, and the person feels unsupported by their employer regarding that injury, we see worse outcomes. Unemployment is a risk factor for worse outcomes. Now that's due, I guess, to the health benefits of work, and also if you think of someone with chronic pain who's at home, has no meaning, purpose, structure, has a lot of time to think about their symptoms, you can understand they might have worse outcomes. Also illness benefits. By this I mean secondary gain factors, so whether it's insurance payments or whether there's secondary gain from the sick role at home, these can impair outcomes.
This next slide, we just wanted to echo the point, and just partly because this is a recent Australian study, and its significance is that the researchers had 715 odd participants. They interviewed them, people whose injuries from work accidents, car accidents were severe enough to get them hospitalised. So they interviewed them in the first week, then followed them up 12 months. They included a whole range of measures, and on the mental health front in particular, the simple K10 was one of their key measures. But the quite important finding was that the mental health status, as assessed in the first week following injury, was the key predictor of levels of disability at 12 months, and it was more than twice as strong as reported pain severity and any sort of indicator of injury type. So just echoing the point that mental health is important, and I suppose practically, GPs are familiar with the K10, and it's not too hard to throw in a K10 into the mix of things that you do when you assess a person presenting with pain problems.
Okay, so now we've sort of set the scene. I guess the next thing we want to go on and do is how to assess the pain and mental health conditions in relation to a work-related injury. So just to give you an overview of assessment, I guess your assessment's actually really important, and I'm aware that in general practice you often have some of this information already from knowing the patient, or you may need to put extra time aside to make sure you have some of this history, because I think it's important to make an assessment of the pain and to do some psychological screening and to make sure that you know if there's a history of substance use and if there's any psychosocial stress involved. And as well as that, I think it's important to assess physical capacity as to where we're going with their abilities and what they can and can't do, the medication use, any side effects from medication, and how the pain and injury is affecting their roles, not just their vocational roles, but also what they're doing in their domestic roles and their social relationships. And I think one of the really important things with this is that sometimes you're going to be involved in a need to challenge this person and their beliefs and maybe go along a bit of a journey with them. And any rapport that you can build through good listening and validating experience can be helpful in the future.
Just on that point, Carolyn, a very, very important thing for GPs on this slide, spending adequate time. I find that sometimes you're not going to be able to cover this in one session. You may have to rebook a patient to take more history, to take more time going through some of those issues. So that does sometimes require a little bit of organisation on your part.
Yeah. And I guess the other part is the physical assessment. And I guess when I examine a patient physically, I've usually got a fairly good history, and I really want to make sure that the patient's report of pain confirms with the physical findings how much congruence there is in their presentation, and also to establish a baseline for future comparisons so that hopefully if they're getting worse you'll recognise it, but also that you can acknowledge improvements. I think it's important to confirm investigation results as much as you can if they're correct. And observing the behaviours, physical examination isn't just about signs. You can find a lot about behaviour in examination. And I think the other thing is that many patients are reassured by a thorough examination, and have been times when patients have actually said, you know, no one's taken the time to do that examination, and even touching the patient and hearing them while you're examining is very important to establish a relationship with your patient. On the next slide.
Can I just say, we've had a question about whether we should do a K10 in every patient with pain or whether only do it with patients with depressive symptoms. Look, I think that's a tough call because, you know, you do have limited time. I would say you don't need to do it in every patient, but if you have any suspicion whatsoever that there might be mental health difficulties, it's probably not unreasonable to do in the first or second assessment. What do you think?
some of the strategies to put that into your assessment. I'll often do it during a consultation. If I know that I'm going to do it again, I may give the patient the survey to take home or complete in the waiting room if they're comfortable with that prior to their next appointment. So that's another way of handling a greater volume of information and getting more information from patients.
Yeah, I'd agree with that. So just going on to the next slide now, I guess it's also important to talk to the patient about what their understanding is, why their pain has persisted after an injury. And often they might feel that they haven't been adequately investigated, or if they've had normal investigations, they need some understanding about how that could be the case. And do they have an expectation of a particular treatment? And what are their expectations of treatment? So I think that's also very important, because that can iron out some of the understanding and start that sort of educative process. You know, it's the thing about, you know, it's not always necessary to do a back pain, an X-ray in simple back pain, but you've got to explain that to the patient and why. Now, we've just got another interesting question, which is asking, would pain scoring be of benefit at this stage? And I personally like to use a little pain score for the brief pain inventory in my practice. A single pain score is often helpful, but it's only what the pain is at that moment. It might be better to get an idea over 24 hours or over the last week. What you're wanting to do is monitor the situation over time. So I personally like having something a little bit arbitrary, like the K10 for the mood at the same time, and a pain score together is probably better than either on their own. So, yeah.
But I'd actually, I don't know if you'll agree with this, but I'd recommend against getting someone to evaluate their pain on a daily basis or over a period of time, because it's just going to increase their attention to the pain.
Yeah. And I mean, sometimes the psychologist might work with a patient and a pain diary to kind of look at developing some different behaviours around particular times of day and things like that. But I think just in the general practice, when we're talking about pacing and stuff, that could be useful. But yeah, not too much rumination about the pain. But it's still, you know, if you've initiated a treatment and someone comes back and says, yeah, my pain is much better and it's more manageable, and it's nice to have a bit of a mark. Yeah. Whereas if someone's continually scoring 10 out of 10 pain, and then you have to look at function really to see where you're going with it.
Or other issues.
Yeah. Polling. So the question coming up
now.
So
moving on to that, we now have a polling question, and the question is, how do you go about evaluating for mental health issues? Option A, suggest to the patient at the first visit that their pain is all in their head and they need an antidepressant. Option B, recommend a psychiatric assessment given that pain and mental illness often go together. Option C, don't evaluate, wait for things to unfold. Or option D, gently approach to exploring possible symptoms of psychological ill health. So, voting's up to 52% of people, 59 people coming back from getting a cup of tea, 67%, 70%. Okay, so far we've got 94% saying it's gently explore possible symptoms of psychological ill health, and we have, I think, 6% saying refer to us for a psychiatry assessment. What do we think of those results?
Yeah. 94.
Yeah.
We need a few more people answering. Come on, guys, wake up.
Yeah.
We got that question back a bit earlier.
So I think in terms of the answer to that polling question, we'd all agree, and I would say that a psychiatric assessment early is indicated if you're sure that the person is presenting with significant psychiatric symptoms that may impact on recovery, absolutely. Just looking at a polling question now, but it's not a polling question.
I'll look back a little bit to the top of that question about mechanical pain, please.
So we've got a long question up. We might hold that towards the end if we've got time. Okay, so moving on to the next slide, mental health assessment. So obviously if you've got a patient who's got chronic pain and you're wondering about mental health issues, my view is to just think about this early, because it's much easier to bring it up as a topic of conversation very early in the piece rather than bring it up several months down the track. So be aware of the possible likelihood of mental health difficulties, build rapport and validate the pain experience. It's really important for the patient to know that you accept that their pain is really experienced rather than making them feel that it's all in their head. You need to understand the broader context of their physical condition, how it's happened, what else is going on in the person's life. I think it's really important to consider how you approach the issue of mental health, and you probably each will have your own framework for doing this. The way I like to do it is evaluate it within a framework of other things. For example, you've got this significant pain. I just want to see what impact it's having on your life. So how are things going? How's it impacting on your relationship? How's it impacting on your ability to work? How's it impacting on your ability to engage in recreational pursuits or exercise? And then how's it impacting on your psychological health? I think it's best to have a few screening questions that you use rather than going through a whole list of symptoms. The ones I like to focus on are ones that can be separated from symptoms of pain, so the general mood and level of enjoyment from activities. Level of irritability, I find it's very common for irritability to be a presenting symptom of depression in this group. It's important to ask about sleep, but also trying to tease out if the sleep impairment is just due to pain or if it's due to cognitive symptoms, rumination, and worry. It's important to tease out their fears and what their anxieties are and whether that level of fear and anxiety is reasonable or whether it is somewhat amplified or exaggerated. I think focusing on their level of withdrawal and avoidance is really important because that's quite a strong marker of functional impairment down the track, and their level of focus and preoccupation with their pain. I also like at this stage to just ask about maladaptive coping mechanisms. For example, I'd like to check in to make sure they're not overusing alcohol to help them sleep or relying heavily on pain medication, for example. Obviously important to have a think of what the barriers or secondary gains might be, and as Ben suggested before, some screening tools such as the K10 are also really useful in this group. I find also at the beginning of assessment it's really important to say I'm going to check in periodically with you regarding the impact on your mental health, so that at 3 months, 6 months down the track, when you bring it up again, it's not, oh my God, my doctor doesn't believe me now. So set the scene early that that's what we're going to be doing. In terms of assessing capacity, and I think this is largely focused on occupational capacity, it's important, obviously, in this group to focus on physical and also the psychological impacts on capacity. So I like to break it up into a few domains to make it simpler. I look at their ability to have structure to their day routine and what their functional tolerances are. So it's, how far can you walk, how long can you sit for, how do you go at standing, driving, but it's also about their sleep-wake cycle and how do they go with the activities of daily living, whether it's self-care, ability to cook, clean, shop, care or responsibility. I look at energy and endurance because obviously mental illness and pain can impact on energy. People often sleep deprived. Medications used to treat these conditions can impact on energy and endurance. So I want to know whether they're resting, whether they're napping during the day. Obviously, if someone's requiring a significant nap during the day, they might not be able to manage much work. How they go after exercise, whether they're able to engage in hobbies, whether they can get through their day. Cognitive capacity is really important because pain can impact on someone's attention and concentration, as can obviously depression and anxiety and side effects of medication. So I ask about their ability to read newspapers, books, whether they can watch TV, check their emails, and their capacity to remember things. I think driving can be a good test of cognitive capacity. Interpersonal functioning is an important one, as is coping. So what's their frustration tolerance? Are they engaging in avoidance behaviours? Are they using substances that will impact on capacity for work? And side effects of medication, I've touched on that already, but that can obviously impact on someone's ability to get through a day and on their cognition.
Yeah, I've been looking at some really good questions coming through, and I really thank everyone for them. There's a long question about mechanical factors in pain, and I guess because I've focused on we focused on the psychological factors, we've kind of assumed that we would do a thorough physical assessment and look at the occupational issues and the nature of the pain and undertake physical therapy concurrently at the same time as addressing these psychological issues. And I'm really pleased to see someone asking if we suggest the use of Oswestry scale, it shows a good level of interest in the disabling effects of pain. So, I mean, you can make it as complex as you want to, and I'm really pleased with these questions, but don't assume that they're not important. They're very important. It's just that we're not talking about that right at this minute. I think also the other question is bringing out issues about pressure from work and triggering a flare of mental illness.
Yeah, there's another question about how do you confirm if the mental illness is related to work or not. Patients may have mental illness issues before work, and I think that's a really important point, and I think it can be difficult to tease out what's work-related and what's not work-related, and I think, I guess you've got a bit of a head start in knowing what the issues were for these patients, often if you've seen them longitudinally before any work-related incident, and assessing how, even if they do have mental health difficulties prior to a workplace incident, has the incident exacerbated their condition, made it worse, prolonged their condition. But it is often difficult to decipher, and it does rely on a lot of history taking and preferably a longitudinal relationship with the patient.
And also 20% of working Australians do experience mental health conditions at any one time, irrespective of the employment environment they're in. That's sort of beyond blue type data that we have.
Okay.
All right.
Keep going?
Keep moving along.
Yeah.
So now we're going to talk about managing pain and mental health conditions in relation to work-related injury.
Yes. Okay. So I guess there's so many options for management of the pain, and I guess we're trying to encourage a broad-based approach, and one of them is some of the non-pharmacological managements of the pain. And I guess one of the things is the embedding of the cognitive behavioural approach within any physical therapies is very important. So, you know, rewarding improved behaviour, being aware of fear avoidance and trying to educate and address it in process of the physical therapy so it's a very natural fit. Sometimes that can involve using exercise physiologists, physiotherapists, doing functional restoration where you're simulating work-related exercises in a sort of gym setting, looking at sort of barriers to recovery and also some gentler things. We, in our program, tend to explore movement a bit. People can become very fearful about movement, so we might try movement in different settings like some relaxation or stretching or just different approaches where somebody might find that they can do something better, looking at postures. And pacing is a big topic for us. We really want to look at some people are overdoers who tend to overdo the kind of boom-bust cycle that we talk about where they overdo and then they have so much pain it's really bad and then they have to slow down. And then we do have some underdoers who are very inactive and need to be encouraged to gradually build up their activity at a pace so that they're not too much exacerbated but so that they can start to function again. I guess from a pharmacological point of view, we rely on simple analgesia as the baseline, sometimes tramadol. If they have neuropathic pain, we might use a different group of medications, which I think we talk about a little bit further on, and they're mentioned there. I'm very wary about the long-term use of opioids. They're often employed following acute pain, but I think we need to be very careful before we continue to use opioids in persistent pain. We need a much more broad-based approach than just medical. And I think, you know, there's a place for surgery and infusions and nerve blocks at times, but generally these things are something to capitalise on the analgesic effect and should be embedded in a recovery kind of approach. We've actually got a question that people keep pointing out about the Arebro pain questionnaire, but I think we've kind of mentioned that already, and I think if you're screening and looking for fear avoidance behaviours and looking at disability and pain, that's a good way of monitoring for improvement. Thank you.
The psychological techniques that are indicated there, I won't run through each individual item, but I will mention that what we tend to differentiate between is what we call active and passive treatments. WorkSafe and TAC have a document we call a clinical framework. It's mainly aimed at allied health professionals, particularly physiotherapists, psychologists, other physical therapists, and it details the principles of active treatment. And they're the same for physical therapies as psychological therapies. We want people to be doing active things. So, for example, if people prescribe physiotherapy stretching exercises, the people who do best in the long run are those who do those on a very regular basis. If a psychologist prescribes a meditation technique, a relaxation technique, or a mindfulness technique, they're going to be much more effective if they're done on a very regular basis. So we do differentiate between passive and active treatments. Very important, people who get involved actively, exercise has got to be very regular, relaxation, all of those things need to be done on a very regular basis to improve the prospects of a better outcome.
Is there any difference in the type of psychological therapy in your experience?
Putting it blunt, the CBT-based approach, there are other sort of nuances on that. People these days talk about acceptance and commitment therapy, interpersonal therapy. So there are other types or related types of therapies that have an evidence base, but the main differentiation is that they're active. Unfortunately, a lot of psychologists who work mainly via Medicare supporting their private practices do sort of passive talking therapy. They don't do they don't get people to do regular systematic activities, practice of strategies that they monitor and reinforce on a regular basis. Those type of the passive talking therapies are singularly unhelpful.
Just in terms of pharmacological treatment for the psychological, just to point out that the antidepressants are used. There's some evidence for duloxetine, Cymbalta, in helping reduce pain, and there's obviously evidence for some of the tricyclic antidepressants in managing pain, but as you all know, these can be sometimes less well tolerated. There's also some growing evidence for other SSRIs in pain management.
There's a question there about if the person has a mental health issue, will this also be under work cover? Well, that depends on whether if it's pre-existing, it may not be. However, if the pre-existing condition is significantly exacerbated, it may well be, or if it develops secondary to the physical injury or pain problem, it may well be as well.
So we wanted to move on, and I guess it's interesting because I've been filling out this talk with a lot of stuff about pharmacology, but the general intention when we see someone with established chronic pain is in fact to see if we can reduce prescribing. We know that only about 1 in 3 or 1 in 4 people get a response to these strong medications. They have a lot of side effects that are counterproductive in that they can be sedating, affect cognitive function. They may have side effects, and often what we want to do is try and simplify and de-prescribe. So that's the first thing, can I rationalise and reduce the medication and still get a good outcome? And often you can. I've mentioned already the boom-bust behaviours, and I think that's a really important concept, of not overdoing and then collapsing and being really a lot worse. I guess, and again, Peter Cotton's touched on this with the idea of actually re-establishing exercise, and it's all about how you do it gradually and achievably and regularly, because you can build on a base. And very much a focus on active therapy, not physical therapy approaches. And I guess there's a whole industry of people who want to go in and have some sort of passive physical treatment, but these are not associated with improvement in function. And I guess one of the big challenges is addressing fear avoidance. People seem to learn very quickly that a certain activity has caused pain, which increases their fear and their arousal and possibly their muscle tension. And then after that, they kind of become so fearful that they can't retry the exercise. And sometimes we have to actually tackle that in stages, but it's a very important part of the physical therapy to avoid that fear of avoidance through pain education and practicing with the therapist to realise that it's not going to be bad. And I think the other thing is sometimes that there's a fear that if I'm hurting that I'm going to be harming myself, but often in chronic pain conditions it's not the case that you're going to harm yourself a lot by having a little bit of extra pain because you've gained some physical function.
You might be doing a lot more harm than good by avoiding.
Yeah.
We've got a good question that's come up about work environment and employer cooperation is a major factor in return to work. As important as the type of psychological therapy we may choose. I couldn't agree with that more. My whole practice is in the occupational health space, and I see injured workers get much worse when they're away from work as opposed to when they're at work in a cooperative and supportive and safe environment.
Recently in the literature we've seen the emergence of the term work-focused treatments. So, for example, there's a well-known study talking about CBT, cognitive behaviour therapy, and work-focused variant, and the study found that people undertaking the work-focused variant of the CBT got back to work much earlier and sustainably.
And I think also if the person's too unwell to be at work, then you need to think of other things in the avocational space. So something to give them meaning, purpose, structure to their day.
Volunteer work.
Social engagement, whether it's volunteer work, whether it's a short course, just something to keep them engaged and active as opposed to feeling alienated, useless, worthless and having all this time to think about their pain and other symptoms.
This next study, we can just summarise this one very quickly, and it really reinforces the point that people in employment that have comparable pain conditions to people not in employment tend to manage them much better and exhibit lower levels or better levels of those various indicators in that slide. I read an interesting editorial from the Pain Journal just a couple of days ago, which talked about whether return to work should be a central treatment objective with chronic pain. And it was saying basically that the worst thing you can say to someone with chronic pain is that you will never work again. It cited some studies which found that in one particular study, 40% of people with chronic pain were able to eventually re-engage with employment through the sort of multidisciplinary type interventions that Carolyn was talking about earlier. So just keep that in mind. You've got to be very cautious about telling someone they'll never ever work again.
Yeah, I think you can often think that's a gift to someone saying you can't work again, you're off the hook or whatever it is, or an IME examiner saying that to someone, and I see it all the time that just causes increasing disability and impairment.
The next slide is a slide I think we've presented before in this webinar series, but it's a statement put out by the Australian Faculty of Occupational and Environmental Medicine, where we try and emphasise the role of GPs in establishing the benefits of patients being at work who have an injury. So we want to portray the message that work is an important part of rehab and that it's a therapeutic intervention. And one other issue is that we don't want the patients to be completely symptom-free before they return to work. Typically, if we say to a patient, look, I'm not sending you back to work until you feel 100%, it is not in their interest, and the literature supports that. Staying away from work will ultimately lead to poorer health. There's a number of medical conditions which are associated with not being employed, and employer-supported recovery will promote an early return to work and help recovery overall, which is what I think we talked about before.
This is a slide probably for more consideration later. It's just to point out that we tend to use different sorts of medication according to the diagnosis of the pain. We've already mentioned the use of the low-dose tricyclics or SNRI drugs and the gabapentin and pregabalin for the treatment of neuropathic pain. So if that's considered, that's an appropriate class of drug to use, whereas with nociceptive pain we tend to use simple analgesics and anti-inflammatories as listed. Next slide, please. We haven't got the time to really go into the detailed study about opioids and chronic pain, but there is really growing alarm about the extent of overuse of opioids in chronic pain. And I think the important thing is to recognise the slide from acute to chronic, and it doesn't mean you should continue the opioids. And I think opioids tend to be sensitising drugs. We know now that opioids have the paradoxical effect through immunological changes and nervous system changes of actually making people more pain sensitive and more heightened pain. Particularly would avoid it in any condition that represents like fibromyalgia. And I think we have to be very careful and have strategies for weaning people off opioids at the same time as we do functional rehab.
Just on that point, I think one of the challenges for GPs is some of their obligations with prescribing opioids. So just an important point to make for all GPs to be aware of your responsibilities if you do prescribe opioids. So treatment contracts, permits through the Department of Health, they're a very important matter in treating patients with opioids.
I'd just like to respond to a question, if that's okay. Psychological damage, injuries, work-related, and the employer is not supportive, then should we let them stay away from work? And I think that's a really important question, because I don't think anyone here would advocate for someone returning to work to an unsafe work environment, but the evidence is clear that returning to work is an important part of the recovery process. So I would say the answer is find out why the employer is not supportive, what's going on, what are the barriers, and can any of those be addressed through open communication, collaboration? Can you get rehab services involved? Is it likely to improve or change, or does there need to be a view at looking at alternate work roles sooner rather than later with a vocational assessment or putting them into the same role, different areas with the help of vocational support? I feel quite strongly about that.
WorkSafe sponsors what's called a new employer service, so that's based on, as DL said, having a vocational assessment and looking at alternative options, and often that involves sponsoring of appropriate training to move in that direction. The other point to make is that if there is genuine concern about the employer being non-supportive or unsupportive, WorkSafe on the other side of the business has return to work inspectors. So if that return to work program is going off the rails, or there's serious problems on the work side of getting the person back to work, the inspectors will go out and do visits and remind employers of their obligations, legal obligations under the Occupational Health and Safety Act.
I'd just like to also make the point that patients can often perceive something and it's very real to them, but it might not be the view of the employer. So it's really important to actually tease out some of the issues rather than just take the patient's self-report at face value. It doesn't mean you're not believing that that's their experience, but they might not have the full story.
And just on that very point, WorkSafe also has a service called the Workplace Support Service, which is what that does is the claims are triaged, and claims where there seems to be more an interpersonal barrier to returning to work rather than a straightforward medical barrier, a skills rehabilitation provider is appointed whose role is to negotiate and get parties together and facilitate discussion and try and resolve any interpersonal barriers.
The next slide, please. I've just put this slide up just to remind you again of the point about polypharmacy, and I think the real problem with polypharmacy is that once you get to beyond 3 medications, there's a real chance that you're getting more adverse side effects than disease benefit. And I think just a reminder, this is from epidemiological calculating for risks of side effects versus the benefit of a medication, and the tipping point is really 3 medications. So maybe that's something we should all put in our pocket and remember. If they're on more than 3 medications for chronic pain, you're probably going too far down the wrong direction.
Wow.
I want to respond to more questions. There's some interesting questions, but we really don't have time.
Okay, well, at this point, I'd like to introduce a case study for discussion, so we might have some more questions filter in as this goes along. So this is introducing a fellow by the name of John, JM, who's a 46-year-old man who works as a cleaner in a local shopping centre. He injured his right shoulder when he was emptying a rubbish bin into a skip. You're seeing him for the first time about 10 weeks after his injury. He attended a colleague of yours who has now unfortunately left your practice, and he made a diagnosis of the patient having a sternoclavicular joint sprain, and he ran some tests. He did a CT scan and an MRI. JM was told that he would have pain for about 2 weeks, and then he could return to work and expect a recovery to take place within about 6 weeks. Your colleague arranged a specialist appointment for him, and the outcome of that was that there was no surgical intervention required. As you read through the background and the notes, you realise that he's had a cortisone injection and he developed flushing of the face, and he was also prescribed anti-inflammatory medication to help him with his pain, but that made him feel weak and tired, and therefore he was reluctant to take further analgesics to control his pain. He was off work initially for 2 weeks and then returned to modified duties. Your colleague referred him to a psychologist prior to leaving the practice, and he tells you that he didn't attend. He's been on modified duty since 2 weeks. He's recently had an occupational rehab assessment done, and you read in the notes that JM is very pain focused. Go to the next slide. So you catch up with him, and during the consultation, John speaks to you for 10 minutes about how severe his pain is. He's very reluctant to consider any alternatives that you offer, citing the previous reaction to an injection. He's tried the anti-inflammatory medicines and they made him feel unwell. He spontaneously reports feeling pain from time to time that can last for between 1 minute and 20 minutes. At home, he has no difficulties with his activities of daily living. He can undertake his household cleaning tasks, including wiping benches, sweeping, carrying the rubbish bin outside, and putting the bins to the curb for collection once a week. He tells you that he's now starting to worry about a lot of different things that are involving his children, his wife, and the pain and what's going to happen to him. You examine him, and you find that he's got mild tenderness of his sternoclavicular joint, full range of movement, and sufficient strength on manual testing of his shoulder girdle. He grimaces every time you palpate that part of the shoulder and the lateral side of his neck. He's been on restricted duties now for up to 6 weeks, folding envelopes in the office, and he's bored, and he wants to consider a return to work for some more active duties. So at this point, I'd like to introduce another polling question. So can I read the polling question? Okay, so option A is, sorry, to preface that, which of the below options would you consider in your discussion with John? Point A, tell John that because his pain is not clear, that he can't return to work until he's feeling 100%. B, reframe and acknowledge his pain and speak to John about a trial of return to part of his pre-injury duties. C, arrange a second opinion for his injury. Perhaps there's some sort of operation that can be done to help. Or D, rearrange another psychology assessment. Are we having some issues with the polling question?
Technical issues.
Okay. So we might just move on to the next slide because it seems like the polling question isn't able to go forward. Sorry. We can't vote, so apologies.
We're running out of time.
We're running out of time.
Yeah.
So I want to answer your question. What happened?
Yeah, we've got
So Ben, what would you do?
I guess what I would do with this patient is probably point B. Have a chat with him about reframing his pain and having a chat to him about trialling some pre-injury duties. And I guess part of that is having a discussion about acknowledging his pain and trying to get some understanding as to how he perceives it. I certainly wouldn't be against point D as well because there's certainly some hints there that there are some psychological symptoms emerging. So dealing with some of those things it may be beneficial to engage a psychologist.
Yeah, I'd agree with that because I think he's getting more anxious, but his pain's sort of extending beyond the area of the original injury, and I think that it's counterproductive to send him off for another specialist or more investigations. But, yeah.
Okay, so we might move to the next slide. There's a question. Oh, okay. Could you read the question out, sorry?
I might read out a question to the panel. Somebody's asked, what happens when an employer could not offer any job alternative to the injured employee, e.g. construction worker, patient, example, because everything involves lifting?
Well, that's when we might rapidly move towards the new employer service, vocational assessment, and look at alternative work that's within the range of functional capabilities that person has.
I think there's a decision to be made there on assessment of whether how long this pain condition is likely to be ongoing for, because you're probably going to rapidly move on to a retraining if you think it's going to be a chronic condition where they're going to have a permanent disability from performing their manual labour work. So there's a bit of a judgment call in there.
And these days, it's 3 months is the marker for which after 3 months, we call it persistent or chronic pain as well.
So that means he'd then get access to this alternative program.
Yes.
And that's the big change, isn't it? The fact that we don't have to just have this non-return to work going on and on and on. That's a really good change.
And if they miraculously improve in the future, then they can always go back to their pre-injury duties anyway. There's nothing saying they can't ever return. There was another question there that I thought was really relevant. Is it compulsory to offer someone work cover if they present with a work-related injury? Do you know the...
It's not compulsory, but of course it's indicated. The person needs to be advised of their rights. If they've been injured at work, then and that's deemed to be a work-related injury, then of course the work cover system and supports kick in. So it just has to be established the extent to which that injury is work-related.
I don't know if the panel's going to agree with me and whether this is controversial, but in my experience in this space, I find that the work cover process of itself can be quite distressing and can sometimes result in worse outcomes just through the process or the distress of the process. And so I think it's also important to inform the injured workers that it is a stressful, that not necessarily always, but just by virtue of having to demonstrate illness and incapacity can be problematic and they need to carefully consider.
There is actually research that being in a compensation for a system for a long time is in of itself causes a worsening of your condition. So, of course it's appropriate to get in, but you want to move on and get out as reasonably quickly as you can.
And I think as a GP, it's part of your role to discuss the pros and cons.
Informed consent, isn't it? You need to know what's involved and you deal with different stakeholders, so some people do need quite a bit of support in negotiating through the processes.
We might just sort of have a quick discussion about this slide as well, and I think it ties in well with that last question about the obligations of an employer to actually provide some workplace, some alternative duties. So under the legislation, in answering that question, the answer is yes. So the employer is obliged to make reasonable adjustments, and whether that's to do with modified duties, whether it's to do with hours, so reduced hours or a graduated increase in hours, and also expectations. So you might have to communicate with the worker and with the employer in some capacity to advise on how long you think it's going to take for somebody to return to work. So I think that ties in with that nicely. Let's move to the next slide. So just to talk about our case study again, after you meet with John, you certify him fit for suitable duties for a period of 4 weeks, as listed in the return to work plan, which you've signed off. The plan excludes any provocative activity for his shoulder, with John starting at modified duties for 12 hours a week, then going up 8 hours a week, up to 24, 30, and then the final week of a 4-month block for your review. You see him for his scheduled review at 4 weeks, and the following information emerges. He didn't go to the psychologist. He's still getting pain lasting 20 minutes and worried that there's something seriously wrong. At work, some of the modified duties still provoking pain, which causes him distress. He's becoming more short-tempered and irritable at home, and he has fears that when he's returned to full duties that his employer will sack him. I just wanted to touch on the new work cover certificate of capacity. I guess that's a new challenge for GPs to fill out. It's been rolled out over the last sort of 12 months. What we're trying to get GPs to do in this space is function on what the worker can do rather than what they can't do, and we're asking doctors to certify workers on what their assessment of capacity is, with the factors that we've talked about in mind. So what we want GPs to do is have their own physical assessment of the worker and fill the certificate in with that in mind. That information can be communicated with the patient. Occupational rehab providers can be involved to discuss what alternative duties are available for a worker in that space as they return to work.
My understanding is you fill out the form to say what their physical or psychological capacity is, not what duties they can perform. It's up to someone else to decide what duties that translates into.
Certification on the basis of capacity, not what you imagine is available.
So it can lift this many kilos for this length of time.
So certification should be based upon medical reasons only. So what we want GPs to consider is what your assessment is of the worker, and again, not focus on what you may or may not know about the worker's environment. Reflect the patient's capacity rather than the availability of suitable employment. Again, it goes back to that previous slide where an employer does have an obligation to provide suitable duties or alternative duties. And TOC and work-safe certificates should only be issued if incapacity is related to compensable injury. So again, we're asking for a little bit of judgment there from GPs to sort of tease out what is related to the work injury and what isn't. So I've now got another polling question here. So we've talked about JM and we've talked about some of the new symptoms that he's reported. So the question is, what are the next steps regarding his evident mental health symptoms? Option A, acknowledge them and recognise that they are part of a normal response. Option B, consider pharmacology therapy, e.g. duloxetine. Option C, re-refer to a psychologist, which he hasn't been to yet. And option D, refer to a psychiatrist. So we're polling.
past halfway, guys. That's fantastic.
This is really good because they're all really good options.
Can we talk now or no?
We're up to 70%.
That's about what I'd expect.
Who's
That's
asleep?
Yeah, interesting.
Yeah, that's really, really good.
Kids, wake up your parents. We're nearly at 3/4. Come on, guys.
It's staying about the same though.
Yeah.
Okay. Whoa, we're getting up to 77%. We're going to close off.
Yeah,
Five,
yeah.
4, 3, 2, 1. Okay, you're out.
Okay, so do we go through the percentages or?
Yeah.
So we have 30% of responders who have responded point A, 24% point B, 26% point C, and 20% point D. So from my perspective, I think that they're all potentially good treatment options, and it's really good that everybody who's voted has thought in a broader context, not thinking there's just one potential option here. And that's the point we're trying to make, is that there's lots of different ways to approach treating these patients. A broader approach is required.
So one comment I'd add is that just from a straight broader mental health point of view, in Australia, somewhere between a bit over 30% of people who do have a diagnosable mental health condition do not seek help from any mental health professional. There are various reasons for that. It might be a deeply felt sense of stigma or shame. It may be a bad past experience. If what I would do with this person too would be explore the reasons why they didn't go to the psychologist when the GP may have referred them originally, and then don't underestimate the psychological impact and value of GP ongoing reassurance, and the GP being gently directive in terms of getting on with exercise and other activities. So sometimes the GP can by default undertake some of that mental health work, as it were.
And you're trained and equipped to do so.
Yes, and a lot of GPs have done extra training in that space, so it may well be that it just is better delivered from the GP than from a referral to someone who doesn't know.
Okay, so the next slide is about referral.
So I think the first point's quite poignant, second is just after the last polling question, but often I'm asked, when do I refer to a psychiatrist? And I think that's a tricky question. I would say refer to one earlier rather than later, but also knowing that you guys are very equipped to manage straightforward mental health difficulties and sometimes more complex ones. But I think, for me, I think about referring, I think when there's a combination of mental illness and chronic pain, then it's already complex. And I think that if symptoms are ongoing at 3 months, then it's definitely reasonable to refer by that point, or if there are other complicating factors such as substance misuse or significant barriers impacting.
So we've just got a question that someone's popped back into pharmacology mode, which we're trying to avoid a little bit, but I do use a bit of Palexia, which is tapentadol, which is a mu opioid agonist and a neurogenergic reuptake inhibitor. I would use that in preference actually to Tarjan, because I generally steer people away from Tarjan for chronic pain conditions, and I guess I see tapentadol as being a bit of a safer, less addictive, milder analgesic. But again, I'd urge you to sort of go for the deep prescribing where possible and look at more rehabilitative approaches. So with the referral, I guess this patient is sort of looking down the line of when we can do a more multifaceted treatment, and a pain management program could often offer that, if it's all well glued together in one place or maybe separately. But I think it's important that it's joined together in a sense that the physical therapies have a cognitive overlay, and so when someone's medical or surgical treatment's not resolving the situation, that acute pain isn't acute anymore, it's becoming chronic. Too much medication and therapies and inactivity rather than active self-management, when there's complicating psychological factors, inadequate coping. And also part of the pain management program does involve motivating the patient to learn to help themselves. It's educationally based. And we also focus a lot in the programs about recognising and treating depression and anxiety, and that can be with counselling and education and or medication. It's not only medication. So I think, and I'm aware that patients with workers' compensation insurance, there's a preferred arrangement with some of these network pain management programs privately who often have quick access. But if they're not compensable and it's an urgent thing, you can always contact a public multidisciplinary program and argue your patient's need.
I'd just add, Carolyn, that what the WorkSafe TAC data show is that referrals to chronic pain programs, whether network programs or other ones, typically don't occur for somewhere like 12 months post-injury, and we know that they're much more effective if those referrals occur a lot earlier.
I agree with you. You said before about 3 months, Peter, and I think, 3 months is when the alarm bells should be ringing, because most people, 95% of people are better in 3 months after soft tissue injuries. And if they're not, you've got to broaden your brush and start to look at it, because the longer it goes unrecognised, the more entrenched a person can become. So I agree. 3 months is when your flag should be waving.
And also, how long's the wait list to get onto one of these programs?
With the network pain programs, they have service. There are programs that WorkSafe and TAC have evaluated and conform to their expectations. They have service level agreements where I don't know what the waiting time is, but it's a maximum time. I think it's up to a few months and no longer. So people can get in fairly rapidly.
It's more reason to refer earlier, knowing that there'll be a delay before they're seen. Yeah.
And that's the thing. Think about it earlier. And if it's a really sort of high urgency case, it doesn't hurt to try at least to speak to someone and triage that person for urgency for their treatment. And the earlier they're seen, the more urgent they are, really, because the less entrenched they are and more likely they are to respond to treatment. So I think many of you, next slide, would know the goals of the pain management program. It's sort of educating. And I think the other thing is it's about adaptation. It's not necessarily offering a cure for the pain. It's actually starting to talk about improving function despite ongoing pain. And sometimes with this approach, we actually see that the pain improves, but that's not our primary goal. It's looking very much at perceptions of pain and suffering. It's educating people that hurt doesn't equal harm, providing some coping skills and strategies. I think also for many people, they're very fearful that people will say it's all in their head. They've had some tests that are very non-specific and they're worried that people think they're crazy. Excuse me. But I always try and say, but everybody has an emotional response to an illness, and sometimes some of these emotional management strategies can be very helpful. So it's helping to take people into that arena of management. And I think the other thing is to increasingly make people more reliant on modest amounts of healthcare services, not excessive amounts. I have to keep going. Okay.
There was a statement about not referring to a psychiatrist early, and I think that's a really important point. And I definitely discourage against inappropriate and unnecessary referrals to psychiatrists, especially given the wait list they have. But I do make the exception when someone is occupationally incapacitated as a result of a work-related injury. If there is a significant psychiatric component, I kind of consider that as almost a medical emergency, that the longer someone's off work, the worse outcome that they will have. So I think if they were at work and they have chronic pain and mental illness, then absolutely GPs are very well equipped to manage that. But if there's significant impairment where there's a risk of long-term disability, then my view would be refer earlier.
I think that's one of the places sometimes where a pain management program can help, because often you've got a team and everybody gets seen by the psychologist in our team, so it's not special treatment, it's just everybody sees a physio and OT, a psychologist and the doctor maybe, and so it's just a package deal, so it's less threatening, but yeah.
A couple of questions there.
Okay, there's a question about whether if there's no major mental health issues, the patient should not be sent to a psychiatrist too early. Otherwise, they invariably end up on more medication rather than psychological therapies. And I mean, that's a fair call for the GP to determine that. I sometimes use a psychiatrist not for long and extended psychoanalytic therapy, but for some medication management guidance. And sometimes the psychiatrist will just see someone once or twice and plan treatment together. So it's according to your own circumstances and context.
First one's fairly straightforward. The long-term patient being inherited with long-term use of opioids, that's where a pain management program may be indicated, because one of their main functions is to help people get off excessive levels of medication.
I guess it's important to start the discussion that one of your goals of treatment will be to review the long-term medication, that our new current thinking in 2016 is that we don't necessarily see that opioids are good for chronic pain anymore, and even though they've been there for a long time, that we would consider withdrawal, at least reduction to a more acceptable level. Start that conversation. Yeah. Thank you. Next slide.
Well, there's one about short-term acting endone.
Can short-acting endone be used for
Again, endone's actually, it really is a very individual discussion, and anything I say is a generalisation, but endone is a very likeable drug with mood effects, which can lead into more regular use and getting withdrawal between doses, making people keep taking. So I'm very wary about using endone for flare-ups of chronic pain. My tendency would be to look at more a stable, long-acting thing, and if I was going to use opioids, which I don't very often, it would be to use something like a buprenorphine patch and looking again at the activity approach to flare-ups and having a management plan for flare-ups of pain that doesn't necessarily involve medication but management, but also restarting activity after a flare-up so you're not getting into this cycle of downward loss of function. Okay, next slide. We've given that talk already. On to resources.
Next slide. Okay.
So Ben, I was actually really impressed to see the professional development resources that the RACGP's developed. I think they're really good.
Yes, so for GPs who treat patients in this area, there are a number of resources that you can access. So some of those are available through TAC and WorkSafe, and we have a number of links to those on this slide for you here. And of course, a number of those modules will attract QI and CPD points for GPs, which is helpful as well. I think there's also some resources that Peter's going to talk to you about next on mental health issues.
Okay, briefly just to indicate, e-mental health is now part of the mainstream and there are excellent resources available online. In the mental health space, there are programs that are treatment programs, not just information programs, and some evaluations indicate they achieve comparable outcomes to face-to-face counselling for mild to moderate anxiety depression. In some of the Scandinavian countries, e-mental health is now completely integrated with general practice. So you get triage through there and you don't get to see a psychologist or psychiatrist unless you fall by the wayside through going through the e-mental health program. So apparently we're sort of heading in that direction. We're a long way off yet in Australia. But Mind Health Connect is the Commonwealth-sponsored site. It takes you to a range of programs from Beyond Blue, Black Dog Institute, ANU University and so forth. Returntowork.net.au is a very interesting site. It's basically anyone returning to work after a mental health issue, and it provides information for the individual themselves, their team members, their manager. I often recommend it to people as a checklist when you've got someone coming back to work to look and see if there are any elements there that you might want to include in the program. So that, and also New Access is a new program, relatively new program, and its main aim is to target people and prevent mild to moderate anxiety symptoms from progressing to becoming over the clinical threshold and becoming diagnosable anxiety and depressive disorders. You do a telephone-based assessment and then you are offered a package that can consist of telephone-based counselling, online treatments and services, or face-to-face, some combination thereof. So they're the key. And lastly, sorry, WorkSafe has a number of return to work resources, and we did mention programs like the Workplace Support Service, where a skilled rehab provider helps to negotiate and set up discussions and try and resolve any interpersonal barriers on the way back to work.
Just wanting to interrupt the resources talk for a minute. It's quite a good question there, asking whether aggressive acute pain management reduces the risk for chronic pain disorder. Certainly, we hypothesise that if people avoid acute pain post-injury or post-surgery, there's a reduced risk of them going on to have chronic pain. That's what the data suggests. But we don't know whether it's directly causative or whether it's associates. But, I mean, definitely addressing good acute pain management is one of our goals for sure, and recognising the people who don't get better early. Just moving back onto pain resources, the next slide is actually a picture from the Agency for Clinical Innovation website. It's called Pain Bites and Pain Management Network, and it has a lot of really good information for professionals, for consumers. It's got great little YouTube videos explaining a lot of concepts about pain. So that's worth looking at. And the other one that we haven't got on the slides but is definitely worth looking up is looking up Pain Australia, which has a really good list of resources for consumers and for professionals on pain management. Probably the one thing where everything's in one place together, so I'd also recommend that. Next slide.
This will answer one of the earlier questions. What was the name of that network pain what? So this will remind people what it is.
So this is just emphasising again that multidisciplinary pain management services are recommended for patients with these problems, whether they be in public or private, and again about the network pain management programs.
There's a list of the approved programs on the WorkSafe and TAC website.
Yeah. Okay then. And then the next slide. This again is just a whole lot of the links. Ben, do you want to talk to this?
So again, this slide provides a number of other useful resources for us as GPs. So there's the WorkSafe website with a particular link to GPs, as well as on the TAC website. We've also got references on there about the role of the GP in return to work, and a number of the documents we've talked about in this webinar, including the health benefits of work and having conversations with patients about returning to work. So there's little clips that you can look at there. There's also information on conversation starters with trying to motivate patients to return to work, and other logistical things like information on invoicing, payments and policies. The certificate of capacity, there's also a link to that. So there was a polling question earlier about the new certificate. So there is a link for that on the WorkSafe and TAC websites. And a number of those resources can actually link into a number of software packages, so especially the certificate into most medical software like Medical Director and Best Practice, which is used by the majority of GPs. And again, just to highlight the role of a number of other resources, so network pain programs, which are very, very helpful for getting patients assessed and treated for chronic pain conditions. Return to work case conferencing, which is a new initiative from WorkSafe to enable GPs to communicate with return to work providers and injured workers to facilitate return to work, and part of that
to be funded for doing that.
And to be funded for doing that. So occupational rehab providers, again, which are part of that process, e-therapy, which Peter's talked about, and outreach services, which are supplied through TAC.
Okay, I just want to make sure that everybody knows that was e-therapy and not ECT therapy. Now, as we draw to a near close, we'll go back one slide, just to let everybody know that there are contact emails, there's provider support. If people want it, there's the case manager for the insurer just at the end of the VWA, the work cover insurer, that you can speak to directly. Everybody should know that there is 3 RACGP QI CPD points available for attending tonight. Certificates will be sent in a few days on the email with the details for the recording and slides. There is a short survey. Please complete it so that we can improve what we're doing. And also, you'll be able to locate this recording on the College of GPs Victoria faculty website. That will take several days to arrive to go through all of that. I'm sure you'd all like to acknowledge thank you to TAC Work Cover for sponsoring tonight, and also to our speakers, Dr. Ben Barisi, Professor Carolyn Arnold, Dr. D.L. Fellman and Dr. Peter Cotton. Thank you all very much, and sorry about the silent introduction to the evening.
Look at that for time, 8 p.m. We kind of sped up a little bit there for a while, and then we got back on track.